Chapter 9, the Hematopoietic System. Erythrocytes, which are referred to as red blood cells, and thrombocytes, referred to as platelets, are both produced in the red bone marrow. Leukocytes, also called white blood cells, are types of cells that are produced both in the red bone marrow and lymphoid tissue. There are two broad categories of leukocytes, and they're granular and non-granular. They're named as to whether there are granules in the cytoplasm. So for example, basophils, neutrophils, and eosinophils all three have granules in their cytoplasm, while lymphocytes and monocytes have no granules. Erythrocytes are the biconcave discs without a nucleus that contain hemoglobin. There are 5 types of leukocytes. First of all, neutrophils. Neutrophils comprise 55 to 75% of the white blood cells. They defend the body against bacteria by ingesting foreign organisms and destroying them through the process of phagocytosis. Eosinophils only comprise 1 to 4% of white blood cells, and they are red-stained cells that respond to allergens. The third type or group are basophils, and they only comprise 0 to 1% of white blood cells, and they contain granules that stain blue. Lymphocytes have a major role in immunity of your body. They comprise 25 to 40% of the white blood cells. And finally, monocytes are phagocytic and respond to areas of inflammation. Thrombocytes, also referred to as platelets, are the smallest blood cells and are essential for blood clotting. Some considerations with regard to the hematopoietic system is that it cannot be imaged. However, many blood disorders will result in abnormalities that can be demonstrated radiographically. Secondly, we must be aware of the severe pain experienced by the patient undergoing a sickle cell crisis. Third, patients with advanced leukemia or lymphoma who have an altered immune status may require protective isolation. And finally, these diseases cause significant demineralization of bone. Therefore, the radiographer must be alert to the possibility of pathologic fractures and must exercise caution when moving and positioning patients. Let's talk about diseases of the red blood cells. Anemia refers to a decrease in the amount of oxygen-carrying hemoglobin in the peripheral blood. This reduction can be attributed to improper formation of new red blood cells, an increased rate of red blood cell destruction, referred to as hemolysis, or a loss of red blood cells as a result of prolonged bleeding. Regardless of the cause, the hemoglobin deficiency causes the anemic person to appear pale, and that's referred to as pallor. There are other clinical findings, and they include fatigue, muscular weakness, and dyspnea. To meet the body's need for more oxygen, the respiratory rate increases and the heart beats more rapidly. There are several types of anemia. Iron deficiency is the most common cause of anemia. It frequently results from chronic blood loss, such as from an ulcer, malignant tumor, or excessive bleeding during menstruation, referred to as menorrhagia. Other causes include inadequate dietary intake of iron and increased iron loss caused by intestinal parasites. It can even develop during pregnancy. We're going to be going into more detail about the other 3 types, which include hemolytic anemia, megaloblastic anemia, and aplastic anemia. Hemolytic anemia. In the term hemolytic, lytic means destruction and hemo means blood. Therefore, we're talking about conditions in which there's destruction of blood. The underlying abnormality in hemolytic anemia is a shortened lifespan of the red blood cells with resulting hemolysis and the release of hemoglobin into the plasma. Spherocytosis, sickle cell anemia, and thalassemia are the major hereditary hemolytic anemias. The hemolytic anemias produce a variety of radiographic abnormalities. Although the findings are similar in the various types of hemolytic anemia, they tend to be most severe in thalassemia and least prominent in spherocytosis. Spherocytosis is the first type of hemolytic anemia we'll talk about. Spherocytosis is a condition in which the erythrocytes have a circular rather than biconcave or disc-like shape, making them fragile and susceptible to rupture. As far as the treatment for spherocytosis, a splenectomy is curative. Sickle cell anemia is a condition in which the hemoglobin molecule is abnormal and the red blood cells are crescentic or sickle-shaped and tend to rupture. Throughout their lives, patients with sickle cell anemia are plagued by recurrent painful crises. For this particular condition, there's no cure that exists. The treatment can consist of management and control of the symptoms. The most invasive treatment is a bone marrow transplantation. In sickle cell anemia, there's expansile pressure at the adjacent intervertebral disc that produces characteristic biconcave indentions on both the superior and inferior margin of the softened vertebral bodies, giving the appearance of fish vertebrae. Another typical appearance is the development of localized step-like central depressions of multiple vertebral end plates. A common complication in patients with sickle cell disease is the development of acute osteomyelitis that's caused by the Salmonella infection. The resulting lytic destruction and periosteal reaction may be extensive, often involving the entire shaft and multiple bones. Radiographically, it may be impossible to distinguish between osteomyelitis and bone infarction without infection, and we can see in this image where the patient has aseptic necrosis of the femoral head. There are modeled areas of increased and decreased density that reflect osteonecrosis without collapse. Thalassemia is a condition in which there's a defect in the hemoglobin formation. This condition occurs predominantly in persons living near the Mediterranean Sea, especially those of Italian, Greek, or Sicilian descent. Extensive marrow hyperplasia, which is a result of ineffective production of red blood cells and rapid destruction of newly formed red blood cells, causes generalized osteoporosis with pronounced widening of the medullary spaces and thinning of the cortices and long and tubular bones. As the fine secondary tuberculi are reabsorbed, new bone is laid down on the surviving tuberculi, thickening them and producing a coarsened pattern. In the skull, there is widening of the diploic space and thinning or complete obliteration of the outer table. When the hyperplastic marrow perforates or destroys the outer table, it proliferates under the invisible periosteum and new bone spicules are laid down perpendicular to the inner table, and this produces the characteristic hair-on-end appearance of vertical striations in a radial pattern. And you can see that hair-on-end appearance pretty well visualized in this image. Extramedullary hematopoiesis is a compensatory mechanism of the liver, spleen, and lymph nodes in patients with prolonged erythrocyte deficiency resulting from the destruction of red blood cells or the inability of normal blood-forming organs to form. Paravertebral collections of hematopoietic tissue may appear on chest radiographs as single or multiple smooth or lobulated posterior mediastinal masses that are usually located at the lower thoracic levels. Megaloblastic anemia. A deficiency of vitamin B12 or folic acid leads to defective DNA synthesis and an anemia in which is a decreased number of red blood cells, although each cell contains the normal amount of hemoglobin. The most common cause of vitamin B12 deficiency is pernicious anemia, in which there is inadequate intrinsic factor secretion related to atrophy of the gastric mucosa. As far as the imaging appearance is concerned, we will be able to see the gastric atrophy visualized radiographically as a tubular stomach with a bald appearance that reflects a decrease or absence of the usually prominent rugal folds. Aplastic anemia refers to a generalized failure of the bone marrow to function that results in decreased levels of erythrocytes, leukocytes, and platelets. In addition to the anemia, the patient cannot fight infection and has a tendency to bleed easily. The causes include exposure to chemical agents or drugs, infections, and invasion of the bone marrow by cancer. Treatment may include transfusions or bone marrow transplantation. Polycythemia. There are two types of this condition, first being primary polycythemia or polycythemia vera, and the second one is secondary polycythemia. Primary polycythemia is a hematologic disorder characterized by hyperplasia of the bone marrow that results in increased production of erythrocytes, granulocytes, and platelets. This disease is slowly progressive and produces symptoms associated with increased blood volume and viscosity. Increased blood volume in primary polycythemia can lead to prominence of the pulmonary vascular shadows, usually without the cardiomegaly associated with other conditions. When looking at this patient, we see that the patient does have an enlarged heart, but it's due to a different cause. Secondary polycythemia may be the result of long-term inadequate oxygen supply in patients with severe chronic pulmonary disease or congenital cyanotic heart disease, or may develop in patients living at high altitudes. Because secondary polycythemia is a compensatory phenomenon, the pulmonary vasculature is normal in appearance and there's no evidence of the disease on chest radiographs. Let's talk about diseases of the white blood cells. Leukemia is a neoplastic proliferation of white blood cells. The two major types are myelocytic and lymphatic, and they're named for the site of the malignancy. Myelocytic leukemia, therefore, is a cancer of the bone marrow, since myelo stands for bone marrow. In this condition, there's a huge increase in granulocytes with a decrease in red blood cells and platelets. Lymphatic leukemia is a malignancy of the lymph nodes, and this is a condition in which there's a dramatic increase in the number of lymphocytes. Leukemia can be acute or chronic. Acute lymphocytic leukemia is one in which there's an abrupt onset and progresses rapidly. It is the most common form in children. Acute lymphocytic leukemia is more common in adults. The chronic leukemias run a prolonged course and may involve lymphocytes or myelocytes. Because of the huge increase in white blood cells, there's generally a decrease in the number of circulating red blood cells and platelets. This decrease in red blood cells results in a typical clinical appearance of weakness, dyspnea or shortness of breath, and cardiac palpitations. The decrease in the number of platelets interferes with the blood clotting mechanism and results in a bleeding tendency. The earliest radiographic sign is usually transverse radiolucent bands at the metaphyseal ends of the long bones, most commonly about the knees, ankles, and wrists. In addition to the radiolucent metaphyseal bands, there is bone destruction with cortical erosion involving many metatarsals and proximal phalanges in this image. Proliferation of neoplastic cells in the marrow leads to destruction of bone. This may cause patchy lytic lesions, a permeative moth-eaten appearance, or diffuse destruction with cortical erosion. And the image shown here, we're looking at the extensive destruction of the bone in both femurs in a patient with acute leukemia. The imaging appearance of chronic leukemia is almost consistently massive splenomegaly. In the images shown here, we see a patient who has massive splenomegaly. In the upper abdomen image, we can see the downward displacement of the left colic flexure. On the right, we can see a grossly enlarged spleen on images taken 27 hours after injection with indium-111 in nuclear medicine. Lymphomas are neoplasms of a lymphoreticular system, which includes the lymph nodes, the spleen, and the lymphoid tissues of the parenchymal organs such as the GI tract, lung, and skin. There are two major types, Hodgkin's and non-Hodgkin's. 90% of the Hodgkin's originates in the lymph nodes. With non-Hodgkin's, the parenchymal organs are most often involved. Lymphoma can spread to all areas of the body, which includes the gastric, renal, and skeletal systems. The most common radiographic finding in lymphoma is mediastinal lymph node enlargement. In the image on the left, we can see considerable widening of the upper half of the mediastinum caused by pronounced lymphadenopathy. In the same patient after chemotherapy, there's a dramatic decrease in the width of the upper mediastinum. Involvement of the pulmonary parenchyma and pleura usually occurs by direct extension from mediastinal nodes along the lymphatic vessels and the bronchovascular sheaths. Radiographically, this may appear as a coarse interstitial pattern that we can see in the image here. Note the enlargement of the left hilar region too. Approximately 5 to 10% of patients with lymphoma have involvement of the GI tract, primarily of the stomach and small bowel. Gastric lymphoma is visualized as a large, bulky polypoid mass, usually irregular and ulcerated, that may be indistinguishable from a carcinoma. And we can see the large mass that's almost filled by a huge ulcer in this image. Another radiographic finding includes thickening, distortion, and nodularity of the rugal folds. You can see in this image how the barium is trying to exit the fundus and go into the body of the stomach and lead to the pyloric canal, but the nodularity of the folds results in a generalized gastric narrowing. Skeletal involvement may be demonstrated in approximately 15% of patients with lymphoma. In this patient with skeletal lymphoma, we can note the shoulder radiograph and T1 weighted axial MR image, in which we can demonstrate multiple lytic lesions with a moth-eaten appearance of the scapula and humeral head. Notice in the coronal and sagittal PET CT fusion images that there's increased uptake, demonstrating the extent of the shoulder girdle involvement. The hematogenous spread of lymphoma produces a model pattern of destruction and sclerosis, which may simulate metastatic disease. The dense vertebral sclerosis, referred to as an ivory vertebra, may develop in Hodgkin's disease. Diffuse lymph infiltration may cause renal enlargement with distortion, elongation, and compression of the calyces. In this image, you can see where the right kidney is completely replaced by a mass. Note the extensive involvement of the lymph nodes. CT, the chest, abdomen, and pelvis, is generally the first imaging procedure in staging lymphoma, especially non-Hodgkin's lymphoma, which tends to produce bulky masses. In this image, we're looking at an anterior displacement of the abdominal aorta away from the spine caused by a lymphoma. MRI is considered the superior technique because it can detect subtle detail with use of multiple sequences. PET has the ability to distinguish large nodes that contain tumors from those that only have benign reactive changes. PET can also be used to monitor the effectiveness of the therapy and to identify tumor recurrence. The PET body scan demonstrates FDG uptake in the supraclavicular foci, the mediastinum, and the lungs. This finding indicates a metabolically active neoplasm, which is consistent with the clinically suspected lymphoma. Infectious mononucleosis is a self-limited viral disease of the lymphoreticulaire system characterized by vague symptoms of mild fever, fatigue, sore throat, and swollen lymph nodes caused by an intense increase of lymphoid cells. The cause may be the Epstein-Barr virus. Mono primarily infects young adults, and although termed the kissing disease, is not particularly contagious. Blood tests show an elevated white blood cell count with a abnormally high percentage of atypical lymphocytes, which resemble monocytes. The diagnosis is based upon presence of the antibodies to the virus in the blood. Characteristic clinical and radiographic findings in infectious mononucleosis include both generalized lymphadenopathy and splenomegaly. Hilar lymph node enlargement, which is usually bilateral, can be demonstrated in approximately 15% of cases. The PA and lateral projections of the chest demonstrate pronounced enlargement of the hilar lymph nodes bilaterally in a patient with infectious mononucleosis. Diseases of the platelets, otherwise referred to as bleeding disorders. Hemophilia is an inherited anomaly of blood coagulation that appears clinically only in males. These patients suffer a lifelong tendency to spontaneously hemorrhage or have severe bleeding from even minor cuts or injuries. The major radiographic changes in hemophilia are complications of recurrent bleeding into the joints that most commonly involves the knees, elbows, and ankles. Initially, the hemorrhage produces a generalized nonspecific soft tissue prominence of the distended joint. Deposition of iron pigment may produce areas of cloudy increased density in the periarticular soft tissues. Eventually, there will be development of multiple subchondral cysts of varying sizes in the medial juxtaarticular bone, as we can see in the image shown here. Hemorrhage extending into the adjacent bony structures may cause extensive destruction referred to as a pseudotumor of hemophilia, which can mimic a malignant tumor. Increased blood flow and atrophy of bone and muscle that may follow an episode of joint bleeding results in severe osteoporosis. Common signs suggestive of hemophilia include widening and deepening of the intercondyloid notch of the femur. Purpura, also called thrombocytopenia, refers to a deficiency in the number of platelets and results in spontaneous hemorrhages into the skin, mucous membranes of the mouth, and internal organs. The acute form of this condition typically involves the sudden onset of severe purpura 1 to 2 weeks after a sore throat or upper respiratory infection in an otherwise healthy child. In the chronic form, purpura occurs in young women and has an insidious onset with a relatively long history of easy bruising and menorrhagia. The radiographic changes caused by the acute or chronic form of this condition primarily involve the GI tract. The hemorrhage into the small bowel produces the characteristic uniform regular thickening of the mucosal folds in the affected intestinal segment, as we can see in the image shown here. In these last few slides, we're going to summarize the imaging appearances. Thalassemia has a hair-on-end appearance. Sickle cell anemia has fish vertebrae appearance. Megaloblastic anemia has a tubular stomach appearance. With acute leukemia, there are transverse radiolucent metaphyseal bands. Chronic leukemia results in massive splenomegaly. Lymphoma can appear as a mediastinal lymph node enlargement and can also appear as an ivory vertebra.